Okay, welcome everyone. I'm glad everyone could join us today. I'm going to start over with my introduction. I'm Michelle Carl, and I'm a volunteer for the PKD Foundation. I have two sons with ARPKD CHF. They are 21 and 15 years old, and you have joined us for Understanding Congenital Hepatic Fibrosis, CHF, and Best Practices for Managing Liver Complications in Children with ARPKD and ADPKD. I'm very pleased to introduce our speaker for this session. Dr. Ryan Fisher is a board-certified pediatric gastroenterologist and transplant hepatologist at Children's Mercy Hospital in Kansas City. He has a strong interest in translational research related to liver disease and transplantation and novel therapeutics to treat disordered inflammation in the liver. Clinically, he focuses on the diagnosis and treatment of liver disease in children, devoting time to children who need or have undergone liver transplantation. And Dr. Fisher has done a lot for us with the PKD Foundation, come to a lot of conferences, and always willing to answer a lot of our questions. So thank you so much, Dr. Fisher. We're pleased to have you here. And Dr. Fisher is going to start with the presentation.
Thank you so much, Michelle. That was awful sweet. And yes, I have really enjoyed my time working with the PKD Foundation and being able to give this talk. I hope it's something that is useful for all y'all. Make sure, Michelle, if anything comes up as I'm giving this, that you let me know, because I'm happy to take a break and answer questions as they come up. But otherwise, for certain afterwards, we can chat. I have given this talk through the PKD Foundation before, and do keep updating it each time I give it, because what's been very cool is that I've learned from the parents in particular, what extra questions they have, and where I need to either be more clear with some thoughts or actually talk about what we've done in our own clinics and things like that. So again, feel free to not just ask questions, but to teach me as well. With that said, I'm going to share my screen and we'll get things going. And let me know if it looks like it's all good on my end. So with that, we'll start off. And activity disclaimer, as well as disclosures, nothing relevant for me to disclose. And we did talk about my background already. So in this talk, we'll discuss congenital hepatic fibrosis, including its definition and how it develops, and then its association with polycystic kidney disease. Now, this is in particular with autosomal recessive polycystic kidney disease, and not as much ADPKD. I don't want to make any parents with children that have ADPKD feel left out. The good thing is a lot of those kids don't develop significant liver manifestations in childhood. But the bad thing is you'll hear me talk a little bit more about ARPKD today. Beyond that, we'll discuss some components of the hepatic fibrosis that goes along with it, including how we get it, and really try to understand and unpack those long-term complications and decide what future therapies might be helpful. So first off, when we talk about congenital hepatic fibrosis, we want to know what it is. And if we go into the medical textbooks, it's a developmental disorder of the hepatoportal biliary system characterized by defective remodeling of the ductal plate, abnormal branching of the portal veins, and fibrosis surrounding those portal tracts. And if you want to break it down, just say the bile ducts and the veins didn't form right in these affected livers. The whole thing should start developing right around 4 weeks of gestation in utero, where the hepatic duct branches out from the nascent lumen of the fetal intestine and really becomes well organized within about 6 weeks. When it's all done, we should see a nice looking liver with a root-like network of bile ducts going through it. Those bile ducts are actually mirrored by the hepatic venous system, which comes in. And I think, please correct me if I'm wrong, does the pointer show up on the presentation? Because if it does, you can see that I'm pointing out the hepatic veins as they go into the liver, and the system that the hepatic veins, the portal vein set up is exactly the same as what the bile duct set up. what's kind of cool about the liver is that it's taking everything from the intestines and stomach and eaten and drank, bring a good one going in. The liver, once it's done processing those nutrients, will of course send it to the heart through the hepatic vein, which isn't shown in this particular illustration. But again, it's a amazing, and in, you know, if you really nerd out about the liver like me, you consider something like that a beautiful thing to see. When we talk about congenital hepatic fibrosis, it's really that early remodeling stage has gone wrong. And what I mean is that if you go back to that 4 weeks of age, there's a ductal plate, which is this green system that's surrounding the growing portal venous system. And usually what's going to happen is that ductal plate is going to break down into little bile ducts, similar and kind of mirror those portal veins. Typically, it looks pretty well organized. You can see those ducts hanging out with the veins. But in congenital hepatic fibrosis, you see a large kind of floppy network of unusual shaped ducts there. With that unusual activity, you get bile, one of the products of the liver, that becomes static inside there. It doesn't get out of the liver as easily as it should, and it can cause scar tissue or fibrosis to develop and cause a lot of the problems that we see for the kids with congenital hepatic fibrosis. And if you look at this pathologically, even if you haven't seen liver under a microscope in your life, what I'm showing here is these are normal liver cells surrounding what we call the portal triad, which is that portal vein right here, this big guy right here. There's a hepatic artery that also comes into it, though we won't talk much about that. And then you can see a bile duct that's kind of that's nice and again mirrors that portal vein quite a bit. When you go over to the right side, you see that you've got some normal looking liver cells out here, but that there's a ton of scar tissue, a ton of fibrosis, and really these floppy, large bile ducts sitting out there that indicate congenital hepatic fibrosis or kind of a fibrous cystic liver disease is present. So again, if we look at it in another way, using imaging, and in this case, MRI, we can see over on the left side what should be a fairly normal looking liver. So you can kind of make the outline if the brightness on your computer's up enough of a nice pyramidal shaped liver here. It's got right and left hepatic ducts coming down into a common duct. There's a gallbladder right there, and that all looks good, and that's what we like to see with little branches of the bile ducts going out. See that it got really jacked up, and you've got big dilated spaces throughout the liver, a liver that's larger than it should be, and these ducts that you can see throughout, some of which are normal size, but some of which are quite dilated. And you can infer that there's a lot of fibrous tissue surrounding all this. You know, if we see this on imaging, this is very close to what it looks like if we were actually to remove that liver, which again, you can see if exactly does this all happen? That's a great question. It's unfortunately very poorly understood. It is often related to mutations in that ARPKD gene, that PKHD1, of which 1 in 70 in the United States are carriers, and of which you guys hear a lot about. There's a number of different portions of the gene that can be affected to create a problematic gene product or protein from this PKHD1 gene. And again, that's just unfortunate because each, having a copy of a mutation on one gene from your mom and one gene from your dad means you're going to get that disease. It's not the only one that is found, however. There are a lot of other genetic disorders that can associate with what we call fibrocystic liver disease, hepatic fibrosis. And of course, while we see the polycystic kidney diseases on this list, there's Jobert's, which I take care of a couple kids with that. Bardet-Biedl syndrome is another one that we'll see, and then some conditions that I haven't even seen yet. As such, it is important for us to talk a little bit about what we mean when we use the language that I'm kind of bringing up here. So congenital hepatic fibrosis, and if we kind of go back to the slide, this Caroli syndrome, are pretty much one and the same. Fibrocystic liver disease is a great catch-all term that a liver doc might use to describe this, where you do have on one end congenital hepatic fibrosis alone by itself, which we might see with ARPKD, without any of those ductal dilatations. Or you could have Caroli syndrome, which would simply be, Caroli's disease, which would be simply all the dilatations without much of the fibrosis. Honestly, either one of those is incredibly rare. What we tend to see is a mix mash in between of both having the fibrosis and having the ductal dilatation, and then essentially what we're going to call either fibrocystic liver disease, referred to as congenital hepatic fibrosis, or you might see it referred to as Caroli's syndrome, where it's not the disease, it's not just the dilatation, but it's that dilatation with the fibrosis. And again, these are just some examples over on the left of cartoons of what the imaging might look like in those situations, where you've got in A, a normal liver and biliary tree. B, that's just fibrosis. So you can see the liver is large, but you see no dilatation. C, where you've got some dilatation, but less fibrosis. And then D, where you end up with both dilatation and fibrosis present to give you that Caroli syndrome. Now, when we talk about, why this happens and where this comes from, why is it that can, if we don't understand completely where it comes from, why does it keep progressing? And so what happens is a combination of not just having those abnormal cysts growing, but also the bile that gets stuck in there. That bile is a digestive enzyme. It's supposed to come out of the liver. If it doesn't come out easily, or it comes out slowly, you're going to drive inflammation, damage, and the need to repair, or that fibrosis that goes along with it. And so we truly know that with this remodeling, you've got these big dilated areas, you've got bile stuck in there, and then you get the fibrosis to go along with it. That's not the complete story, because certainly these kids just develop extra fibrosis anyway, but it certainly doesn't help that we have both the fibrotic process there and also those big dilated areas. And unfortunately, now that we do kind of understand, at least a little bit where it comes from and how it progresses, with those different components, we really have a hard time fixing it up. So we have to focus on managing these long-term complications. This includes immunization for hepatitis A and B, super, super important, because if you already have, you do not want to get another disease on top of it. It's not 1 + 1 = 2, it's 1 + 1 = 8. You do need to monitor growth, development, and nutrition in these kids. When bile doesn't get out of the liver easily, they're at high risk for vitamin supplementation. Bile is a digestive enzyme. It's supposed to help you absorb nutrients, including what we call the fat-soluble vitamins. Of course, you avoid alcohol. And you really do try and live a healthy lifestyle where you can. From the kidney side, we always talk about salt and things like that, but the liver has some stuff it doesn't love either. One of them, the liver doesn't love to sit around. It likes to move. It doesn't want to just store energy for us. It wants to take that energy that it gets from your diet and send it back out to the body. Two, it actually really doesn't love sugar. We find that sugar and alcohol, especially high fructose corn syrup, appear a little bit similar when you break them down. And if you can avoid table sugar and really sugary, sweet, or processed foods, you're going to do yourself a big favor. Certainly other items like antibiotics, or even what we call choleretic agents, or kind of bile thinners, can be useful. And then avoiding things like ibuprofen, especially if your liver disease is advanced, become important as well. But again, ibuprofen is not a kidney friend either. So with all this said, if you do have congenital hepatic fibrosis, what could possibly go wrong? Well, it's obvious that you're going to run into some troubles. And that fibrous and scarred liver can cause what we call portal hypertension. And you remember I was talking about the portal vein there. Well, that vein running into the liver, delivering nutrients from the intestine, is a great little guy. But when the liver is really beat up and scarred up, as you can see in this cartoon here, it doesn't allow flow through the portal vein into the liver like we would expect. And so the portal vein gets congested, it gets bigger and thicker, and we start to see problems related to that. And we call those problems complications of portal hypertension. But what can develop is that blood backs up, is that blood vessels, which would normally flow nicely into the liver, become congested all along, not just the intestines, but also the stomach and the esophagus. We can actually see these gastric and esophageal blood vessels stick out in the form of varices. You can see a spleen, which is a really, vascular organ, get bigger. And so when you feel on your belly, that spleen gets really big. And that's why we have to limit contact sports, because that has a possibility of rupturing. And you can even see, even though it's not illustrated here, that if this blood backs up into the intestines, that you might get leakage out of those intestines in what we call ascites, or fluid in the belly. As I mentioned, kids who do have fibrocystic liver disease can have significant GI issues, and one of them is the development of these varices. And I think it's really apparent over on the left-hand side, where you can see these big blood vessels, these congested blood vessels that just can't deliver the blood to the liver like they want to, and so they start to back up. They're not a big problem other places in the intestines, but here in the esophagus, where I've got a good picture of a scope there, you can see that they can get really congested, and they're close to the surface. If you look up at the top, you can see that there's a little blood there. And what can happen is that these guys can bleed. It's a dramatic presentation when they do, because if you imagine blood from, say, an esophageal or esophageal varix kind of drops into your food pipe, goes down into your stomach, that blood is really irritating to the stomach, and your kid's going to throw up, and it's going to be bright red blood that comes back up. It doesn't happen often, but it is a dramatic effect, and we do like to make sure we watch our kids with ARPKD and congenital hepatic fibrosis to see if they have any of these varices developing. Over on the right, this is what you hope to see. This is what the esophagus should actually look like, nice and smooth without any of those blood vessels, just to give you a frame of reference. Now, when they do develop, like I said, they're difficult, but they're certainly manageable. And one of the cool things that we can do is, if you see over here on the left, that's a picture of a scope that goes down into the esophagus. Like I said, we'll do those regularly in some of our ARPKD kids to see if we can find blood vessels. And if we do, we're going to go down with a special tool that actually kind of sucks those blood vessels into a suction canister on the end of our scope. And then we fire a rubber band down around it so that it basically kind of strangles that blood vessel and takes it away for us. And you can see over on the right a good picture of that rubber band kind of making mushroom-shaped appearance of the blood vessel underneath it. In about 1 to 2 days, that'll all be dead tissue, and it'll fall off nice and easily. And it really limits your risk of bleeding happening in that situation, which is great to see. And as I mentioned, not every kid's going to have these, but they are a relative complication of congenital hepatic fibrosis. So when we talk about their development, you can see that in kids with portal hypertension, so with some signs of that spleen being enlarged, about 80% of them by the 11 to 15 years are going to have these varices in place. And it becomes an important idea for us to really talk about and co-manage with our nephrology colleagues. Again, not everybody's going to do it, but over time they certainly can develop it in those kids who may have some of those findings of portal hypertension. So with that said, that's kind of one of the main ones that I talk about, especially with parents, because when you do find it, A, there's something you can do about it, but B, it's also quite dramatic, and it can be pretty scary like that. And so, are there other things that we need to watch out for or talk about? And yeah, there certainly are. As I mentioned, fibrocystic liver disease or congenital hepatic fibrosis, you can have those big dilated areas of bile. Well, those are kind of like, those are easy to become infected. And unfortunately, bacteria, which would normally flow out in the bile or not be able to get up into the liver from the intestines where they normally do live, can kind of crawl up in there. And when there's those big dilated areas and that liquid just kind of sitting there, the bacteria have a great home. They can replicate, they can start causing a fever, and we can get what we call cholangitis, or an infection of that biliary system. The infection is most notable for it's what we call the Charcot's triad, named after the doc who kind of first described it, but it includes having that fever, turning yellow, and having a lot of pain in that right upper side by your liver. Now, there's other reasons you could get it. Perhaps a stone has moved through and is blocking things up. But when you do have congenital hepatic fibrosis, it's one of the big things that we always think about and that we worry about when our kids have fever, especially with elevated bilirubin levels and that jaundice and right-sided pain. Honestly, I tell folks it's those big dilated areas within the liver are just kind of like a bacterial hot tub. They love sitting in there and getting all their buddies, and it's something that you do want to be ready for. As I also mentioned, portal hypertension, this difficulty of the portal vein getting blood into the liver can also kind of push fluid back and create what we call ascites. And you will see that in renal failure as well. But when that liver is really beat up and fibrosed, the ascites can come from these liver conditions. And again, that can fill up with fluid. That fluid is another reservoir for perhaps infection, which we would call bacterial peritonitis. So bacteria may not only love living in those dilated ducts, they love living in ascites. And it can be something where we actually need to drain the ascites to either help diagnose or manage the problems that a kiddo may be having with it. And when it comes to any of these complications, whether it's the varices or the cholangitis or the ascites, we always want to know, okay, hey, not just are you aware of it and can you diagnose it, but can you do anything about it? And there are a couple things that we can talk about. And for certain, when it comes to the varices, we do often recommend beta blockers, especially in our older kids, to try and reduce some of the pressure in that portal venous system. That seems to help kids not to have any bleeding complications related to that. We typically won't use it until we really do see or have a complicated or have varices that have actually bled in the past. But at the same time, we do use it and do find it to be somewhat helpful, at least in our practice. When it comes to bacteria in the liver, like cholangitis, IV antibiotics are a must. It's really important to get those sooner rather than later if that infection is proven. And then sometimes we do have kids that take antibiotics every day or every other day just to prevent infections. Ascites, same thing when it comes to infections, but that can also be helped by limiting sodium in the diet, even more restrictive, say, than a kid might be used to, or using some of the diuretic medications like Lasix and spironolactone to help remove some of that fluid from their body. And then finally, as I mentioned, there are things that thin the bile. Ursodiol is kind of what we call one of those choleretic agents that helps make that bile a little more water soluble. And then we can also always talk about adding vitamins and to help kids out with their medical care. And then certainly we always love to see our PKD kids in our clinic. What we'll do is a good clinical exam, of course, but we have some tells that we like to look for. So one is do we notice that the spleen is really big on that? You can actually feel it sticking out underneath the liver of some kids who have advanced portal hypertension. That becomes important. You might see that they have really prominent blood vessels on their abdomen. Now, if they're a pale kid, those vessels may be prominent as well. These can be really striking, and an easy way to at least be concerned that maybe portal hypertension is present. Looking at the labs is another great tool. The platelet count is interesting because platelets, which help us clot our blood, get trapped in a large spleen. And when you kids who been worked up for, they think something's wrong with the bone marrow or something like that.
We didn't hear what you
end
said.
up needing to really just do a good workup looking for that portal hypertension.
We lost you
I
there.
apologize for that. Am I back on now?
Yes, you're back on.
Okay. Okay, it looks like my connection is good now, so sorry about that. Yeah, so we look at INR, which is a measure of coagulation. That lets us know how the liver's functioning. We'll look at platelet count, where those platelets can get trapped and go up if that bile is really stuck inside the liver. And GGT, which is an enzyme that comes from the cells around your bile duct, what we call cholangiocytes. When you have a lot of bile stuck in there or any inflammation, that GGT is an enzyme that may go up. So those are things that we'll check out there. In our clinic, we always get ultrasound to start off with and see what's going on inside the liver of a kid. I think that's really important. And then, as I've mentioned, MRI can be a useful adjunct tool to give us a lot of in-depth looking at that biliary tree. And then finally, as I mentioned with varices, we do consider these screening endoscopies in kids. Now, no one test is completely predictive, but if you put these all together with your clinical exam, you can really get a good idea of if you think a kid is advancing with their portal hypertension and having problems or not. Some of them aren't easy to do necessarily. I find that, there's certainly kids who have a hard time with lab work. Ultrasound is pretty painless, but they do have to be able to cooperate a little bit with the radiology tech. MRI and endoscopy are procedures that require sedation. We may not do those in real little kids just because the value at a young age isn't quite worth it, but we may, move forward and recommend those certainly later in life. Or again, if we find that, the lab work or the exam is concerning. There are some, beyond looking at, say, like an endoscopy or, putting them to sleep so that we can get a good MRI, especially in a younger patient, some non-invasive ways to look at the liver itself. These would be ones that can, say, measure fibrosis without us necessarily needing even what we would consider like a liver biopsy per se. And so these non-invasive ways can use ultrasound technology, like what's exampled here, where we use a special machine called either FibroScan or in this case, shear wave elastography to measure the stiffness of the liver. When the liver has a lot of fibrosis in it, you can turn on your ultrasound machine and measure that stiffness, measure the velocity that those sound waves go through the liver. And that gives you a great idea if you're if you have a lot of extra fibrosis, or if perhaps your liver's in a little bit better shape than maybe you thought it was. It has been proven to be pretty good at identifying kids with portal hypertension. What you can see here is that in kids where we measured in blue the left lobe of the liver, in red the right lobe of the liver, and then in green the spleen. When we did those liver measurements in kids without ARPKD and kids with ARPKD, those numbers do go up. And then if you look over, I'm going to try and minimize this. If you look over at this graph on the right, you can see that when you have kids without ARPKD, and then when you have in the middle here kids with ARPKD but without portal hypertension, so not a lot of fibrosis in that liver. And then when you have kids with ARPKD and with portal hypertension, you get stepwise, incremental increases in what we call this shear wave speed, or this measure of liver stiffness. So it does seem to work relatively well for letting us know, hey, is this liver really beat up, or is this liver still feeling okay? That said, is there anything else that we need to be ready for with our kiddos? And if we take a moment to talk about autosomal dominant PKD, absolutely. There's some other, non-kidney, non-liver manifestations of ADPKD. They include aneurysms. I think that's a really big one that we talk about. Cystic disease of not just the liver, but even the pancreas, or sometimes issues with the lungs themselves. And ARPKD has some features as well. You can have underdeveloped lungs. Cerebral aneurysms have been reported, so they're not just an ADPKD thing. High blood pressure can happen, those same pancreatic cysts, and then of course the hepatic manifestations where you have either those large cysts in the liver or even those development of varices. Again, not as big a deal for the ADPKD kids as it is for the ARPKD kids. So while the livers, of a kid with ARPKD or CHF does have issues, it really still usually functions quite well, meaning that those liver cells inside there are in good shape. They are capable of doing all the things that a liver cell should do. Just because they have that scar tissue around them doesn't mean they don't work. It means, yeah, they can work really well, but it's just that the complications of having that scar tissue, that portal hypertension, that really drive us to need to be careful with it. One of the thoughts is that, well, okay, if you can get around the liver somehow, could you perhaps eliminate some of these complications that we see, whether that's the varices or the ascites in the belly or the large spleen? And the short answer is, yeah, in some cases you can. So what this represents is what we call a shunt surgery, where a surgeon takes splenic vein, and instead of sending it into the portal vein, which is having trouble getting through the liver, they go ahead and put it into one of the renal veins. Now, this may or may not be the best idea in someone with, say, like a severely affected ARPKD, but there's some other options where, say, this you could do like a splenocaval right into here. Regardless, when you get that blood supply going in a different direction, it doesn't go through the liver first. It goes actually around the liver and then gets into the liver through the hepatic artery on kind of a second pass. This ends up being physiologically pretty good for a lot of kids. Now, that said, there are some, things that we eat and bacterial products that are supposed to go to the liver first without going to, say, up into the heart and then maybe the brain first. And so, it's not perfect in that you do put kids at risk for, say, a little bit of what we call encephalopathy, where some of those either bacterial products or breakdown products aren't getting metabolized by the liver right away. They're getting metabolized, but just not right away. And that can affect, say, maybe like school performance or create a little ADHD in some of the patients that we see. So, it's not a uncomplicated surgery from that perspective, but it is one that, especially if you're having a lot of trouble with either the bleeding or the fluid in your belly, you might take a look at. But beyond that, if you really do run into trouble with your congenital hepatic fibrosis and its complications related to portal hypertension, transplantation does have to be thought about. The big time complications that we see, where we would say talk to a family about, hey, this liver in this setting isn't doing the trick, would include recurrent episodes of that GI bleeding, especially if we can't fix it with our scopes, recurrent infections, or perhaps the fact that the liver's pretty advanced and, while it hasn't had many complications, the kidneys are looking like they might need to be removed and transplanted. And so do we want to consider doing both at the same time? And, just to kind of put it in perspective, when it comes to, ARPKD, we do see types of transplants in these kiddos.
We lost you there again. We can't hear you, Dr. Fisher.
It is almost a decade old, and we're certainly seeing that getting bigger.
You're breaking out again. We're not hearing you.
Hear me now?
Yes, I think so. Try again. No.
And are you able to hear me now?
Oh, yes, now we can. Nope. We don't hear you at all. We don't hear you at all, Dr. Fisher.
Okay. Now am I back in there?
Popped out. Okay.
Yep.
Yes, now you're back.
Now, did I get back in?
Yes.
Okay, sounds great. Okay, I'll keep going and just holler at me if it pops out again. Sorry about that.
You're breaking up a little bit right now.
Oh no.
We have about 10 minutes left.
Okay. And what I can do is try and wrap up real quick here then.
Okay, and we do have a couple of questions, so hopefully we can get to that.
So, obviously when it comes to talking about transplant, early disease predicts a higher likelihood. So the kids that present later in life or maybe aren't noticed right away are going to go a little longer without transplant, especially liver transplant, than those who maybe are caught a little bit earlier or noticed a little bit earlier. But that said, patient and graft survival is truly excellent in kids, whether we're considering a kidney transplant only or liver transplant only or combined liver and kidney. And certainly over time, we've gotten better at it, which is really great to see. So does this mean that, we can talk about normal living for kids with ARPKD? And, I always tell folks, yeah, this is completely what I expect, 100% normal lifespan. Now, you may have medications and bumps in the road, but at the same time, getting to do what you want to do is going to be important. And so with proper surveillance, I really do think that we can get close to having just a super good life for these kiddos. So again, when it comes to looking for liver disease, we like to use our physical exam and lab work, as well as imaging. And then if, it is a kid, say, that we would have here in Kansas City, once the renal docs have decided that it's a good time to maybe have them come talk to us, we would have that initial visit. That would include that lab work, that ultrasound, and then, MRCP if they're old enough to do it without anesthesia, and endoscopy, again, if they've got some signs of portal hypertension. And then we set them up for those annual visits with lab work, vitamin studies, ultrasounds, and those liver stiffness measurements whenever we can. After, every 3 years in our system, we do like to repeat those MRCPs and endoscopies in addition to having those annual visits. And so it does tend to be something where we like to establish a good long-term relationship and in pretty much every step of the way. With that said, since we just have a few minutes left, I'll go back over and stop sharing now. And we can chat a little bit about, what kind of questions you guys may or may not have. Sorry for the audio there.
Oh, that's okay. So the first question is, when should you start doing a scope on a child with ARPKD? What factors do you look for to know if one should be done? And then I'd like to add, how often would you do them?
Yeah, no, I think it's a great question, and kind of going back to that last slide there, is one that we've tried to at least make a protocol for the kids that we see. So the one thing that I can't say is that I know that there is an age where you need to do X, and it really isn't like that. What you do need is you need that clinical suspicion to start doing those type of cares that you want to do. For us, that clinical suspicion comes usually from the kidney doctors when either they're like, hey, I did an ultrasound and the liver looks really bumpy or it looks really affected. Okay, that would be a good reason for them to come see us. If they feel on exam that the liver is super large or that the spleen is super large, yeah, you know what? I think it's good to get checked out by your liver doc. For our ADPKD kids, if they have a large hepatic cyst and the kidney docs just are like, hey, will you guys please look at this? That's when we're there. Our door for kids with ARPKD is always open. And so we love to see them, even if the liver hasn't been affected by anything yet, we're all in right away. Now that said, when we might, to kind of take it further, when do you do all those things? Well, for us, we've decided that we're going to do an MRI or what we call the MRCP, which is MR cholangiopancreatography, but it gives us a nice look at that biliary tree every 3 years. I won't do that before usually age 7 or 8 unless a liver is really affected, because that does require a little kid to be sedated to get good images. Now, once they get to be 7, 8 years old, they can lie in the MRI machine and watch a movie for about 45 minutes. Then it becomes a lot easier to do it without any kind of anesthesia. For endoscopy, we will wait until they have some signs of portal hypertension on their exam or on their lab work or imaging. We've got to see some kind of indication before we'll say, we need to go use our scope. But once we've seen that, for us, it does become important that we go ahead and take a quick look. We'll do those looks every 3 years. If kids have had varices present, we might go and look every year or two. If they've actually been a kid who we've done a rubber band on or done that band ligation on, we may come back within 3 months after that band ligation to see how things are going and perhaps repeat it until we get rid of those varices altogether. It really just depends on the patient. But again, for the most part, referral to a liver clinic sooner rather than later is great. But when it comes to, what's the age where you need, say, the MRI or the endoscopy or this or that, those more invasive tests, that still has to rely a little bit on the clinical situation.
Great, thank you. And the next question is, have you had patients with CHF who have developed liver nodules? And if so, how often do their liver nodules need to be removed?
We have not had any of our patients, say, develop liver nodules. And would this mean like a liver cancer, I think, per se? Because what we'll see is that, they can certainly get large cystic disease where, say, a cyst is so large on one side of the liver or the other side of the liver, and that people think about taking that portion of the liver out and then leaving behind a relatively unaffected side of the liver, if that's the case. So let's say you're getting a lot of infections and you have this huge cystic dilatation of the left side of the liver. It's possible to remove that side of the liver, let it grow back, and in theory, take away some of that infectious risk. That's only if everything else looks really, really good all throughout the system. It's a rare step to take, and I've really only seen it in one patient. Now, as far as developing, say, like a liver nodule, you do have to worry about cancer development in the liver, and that's something that I didn't get to share, but we do need to be aware of some of the risks for what we call cholangiocarcinoma, especially. This is a special cancer that happens inside the cells of those bile ducts, and you can see here, around in ARPKD kids, they start to pop up in the 4th, 5th, 6th decade, where you get those cholangiocarcinomas. We do have some case reports of them happening in kids as well, and so it's one of those things where we don't necessarily plan on, say, removing nodules from a kid with ARPKD and congenital hepatic fibrosis, but we are looking for nodules because we want to make sure that there wouldn't be, say, a cancer developing.
Okay, great. Thank you. The next question is, do you recommend long-term use of reflux medications? And is there one that performs better than another for these kids long-term?
Yeah, and that's kind of going on to the GI side of things, which is, it is a big deal for a lot of the ARPKD kids and sometimes the ADPKD kids that we see. I don't recommend any antacid over another necessarily, and I don't think that they have to be on. But in situations where either having this huge liver is making it so that your kid is throwing up or having some reflux type symptoms, it can be a really helpful medication for those kids. We have a few different categories. We used to use a lot of Zantac. That actually got a black box warning because of EDTA that was kind of a preservative found in the Zantac. They didn't want to keep giving that to people, thinking that it could in fact create a cancer. While there's no direct correlation that anyone's found, it was enough of a risk that we've stopped using that. And instead we like to use Pepcid, which is basically about the same type of medication. A little bit more effective, but also more expensive alternative to Pepcid, or what we call famotidine, would be the proton pump inhibitors, and you've heard about all these, Nexium, Prilosec. A lot of them are over the counter now, but those tend to be really good acid blocking medications. And if your child does have symptoms of reflux or general abdominal discomfort, using them and seeing if they work for your kid is a really good idea. Now, there are some people who advocate for them in kids who have those varices that I described, because you're like, well, what if you reflux into your esophagus and that irritates those big blood vessels? Could that make them bleed? And some people do think that that's possible. So, if we do see, really bad like redness and irritation of some of those blood vessels, but maybe not perhaps anything else going on there, we might go ahead and prescribe an acid blocker, whether that's the famotidine or one of those proton pump inhibitors for those kiddos.
I'm glad everyone came. Thank you very much, Dr. Fisher, for your time. Please don't forget to take the survey for this session. And I am a little bit confused about the timing, but it says to stay right here. Up next, we have a mindfulness break. When you're ready, leave the Zoom meeting and navigate back to the virtual platform. Our next breakout session will begin at 2:45 Central Time. I was a little bit confused about the mindfulness. I thought it was after our last one. So I'm going to quickly type in my email address here, and you can also reach me at the, I'm sorry, hold on one second. You can also reach me at the PKD parents email address. And if you're not part of our Facebook group, we would love for you to join our Facebook group, PKD and Children Parents Chapter, which it's for children with ARPKD and ADPKD. So a lot of different parents are there, and there will be a recording, yes, of this. Someone just asked that. There will be a recording of this liver session that we just had, and they said that they might just reach out to you, Dr. Fisher, for a couple of parts where we couldn't hear you.
Yeah, and I really do apologize for that. I thought I had a pretty good connection going there. So again, thank you guys for the opportunity to do this. And I really, really like, again, not just working with the PKD Foundation, but working with the kids that we've gotten to see here in Kansas City. The families are awesome. So it's, yeah, I'm more than happy to tackle these things. And I'll type my email into the chat here just so everybody has it and can reach out if they've got some extra thoughts or anything like that too.
Perfect. So can they email you with their questions that we didn't get a chance to go?
Yeah, absolutely. Okay. Be happy to address those, go over those. So
Marianne, I think you're still on. We didn't get to your question, and I don't know your first name, but Garcia Everett. So go ahead and email Dr. Fisher, and he'll try and answer your questions for you. Thank you so much for your time. Thank you everyone for coming, and hopefully I'll see some of you at the round tables later on. Thank you.
Thanks, Michelle. Take care. And I apologize. I thought I had till 2:40 or 3:45 there. So my bad. I was slow playing that a little bit.
Well, I did too. And so I actually at 2:20 I said, what are we over at 3:30 or 3:45? Because then on my sheet that they gave me that I was supposed to read, it said 3:30 my time, and I'm so confused. And then she said actually 3:35. I think
I am so sorry.
No, I think they actually changed the times and they didn't let us know.
Okay. So. Okay. Well, I was like, oh shoot, I usually can get these things down pretty close to where I want them. So that was.
I think we're all just trying to navigate this virtual platform.
Isn't that the truth?
Yes.
Yeah.